Cardiovascular alterations. The leading cause of death and disability in the United States for both men and women are cardiovascular problems, and it costs over $6 billion annually to treat patients who have cardiovascular disease. Keep in mind that the heart is basically just a pump, an expensive but very efficient pump. It consumes 75% of the oxygen we breathe in, and it takes it first. The heart must obtain an adequate oxygen in order to function well. It contains 4 valves and 4 chambers. The valves are auscultated, if you remember from skills, as ape to man sites. Aortic in the second intercostal space, right sternal border. Pulmonic in the second intercostal space, left sternal border. Tricuspid in the 4th to 5th intercostal space, left sternal border. And mitral in the 5th intercostal space, mid-clavicular line. The mitral site is also called your PMI, or your point of maximal impulse. The tricuspid is on the right. It's spelled TRI, so it starts with TR, so it's on the right. And mitral ends in L, so it's on the left. It's one way in which I remember the difference. That's why I don't call them tricuspid and bicuspid, but tricuspid and mitral. This is a diagram of the heart cut in half. It shows the superior vena cava up here at the top, and the inferior vena cava down at the bottom. So the blood comes in there into the right atrium, comes in here to the right atrium, through the tricuspid valve into the right ventricle, then out through the pulmonic valve into the pulmonary arteries where it goes to the lungs. Then it comes back in through the pulmonary veins into the left atrium, goes through the mitral valve into the left ventricle, and then out the aortic valve into the aorta. That's your normal circulation through the heart, and you should be able to do that both forward and backward, because forward is normal and backward is disease. Remember that the right side receives only venous blood, and the left side receives arterial blood. Arteries carry blood away from the heart into the body, and veins carry blood back to the heart. That's what's very important to know. By the way, because this content is so very important, and there's a lot of it, this lecture will be in 4 parts. And this is the first part. So, this is a diagram from the memory book, trying to help you to identify what S1 and S2 are. S1 is closure of your tricuspid and mitral valves. Please remember that when valves open, normally they make no sound whatsoever. It's only when the valves close that they make a sound. So the S1 is lub. It is closure of your tricuspid and mitral valves. It is the beginning of systole. So you should hear the S1 loudest in the 4th to 5th intercostal space, left sternal border, or in the mid-clavicular line at the PMI, because that's your mitral and your tricuspid valves. Now, remember, the sound that you hear is not over the sound of over the location of the valve, but where that sound radiates to, where it sounds the loudest. S2 is closure of your aortic and pulmonic valves. This is the dub sound. It is the end of systole, because the ventricles have now contracted, because that's what systole is, when the ventricles contract. So they start to contract with the lub sound, closure of S1, blood is starting to, the pressure is building up in that left ventricle to push the blood out into the aorta, pushing the aortic valves open, again no sound, and then pushes the blood out because you have contraction. Then you have closure of the aortic and pulmonic valves. It causes the dub sound, and now it's the beginning of diastole, or when the heart is at rest. So S1 is the beginning of systole, S2 is the end of systole and the beginning of diastole. Any sound that occurs in diastole is abnormal. That's why I like to think of S1 as the beginning of systole and S2 as the end of systole, and thus making them both systolic sounds. Some references list S2 as a diastolic sound because it's the beginning of diastole, but then you can't make the statement that every sound in diastole is abnormal because S2 is totally normal. So if you consider S2 as a systolic sound, because it's the end of systole, that makes it a normal sound. This will come in handy to remember when we talk about valves, and that'll be coming up. But this is all normal stuff. Now we're going to start talking about some of the abnormals. Disease of the veins. Varicose veins are distended, tortuous, and palpable veins. Tend to occur as we age, not in the children, but as we get older, due to many, many years of standing. Patho, keep in mind that your veins are highly distensible. They expand really well. They're very thin-walled so that the waste products can come back in and the blood can go back. So it's very thin. And they contain valves to prevent the blood from just staying in your feet all the time. It encourages the blood to move along toward the heart. But those valves can be damaged over time. Increased hydrostatic pressure can cause that, and that's when you have somebody who has edema. That will damage the veins. Or if they have trauma to the saphenous vein, which is the largest vein in the leg. Like if you're wearing really, really, really tight jeans, or tight hose, or bands around your legs. Gravity also has an effect, pulling the blood back down towards your feet, and that can damage the valves. Some of the risk factors for varicose veins are standing for a prolonged time. That's why most instructors move back and forth in the room when they talk, because otherwise they have no circulation to their legs. That's why soldiers at Buckingham Palace can pass out, because they're not allowed to move for a full hour, and that causes the blood to pull away from the brain, and so they will pass out. Crossing your legs at the knees can cause this to occur also. Or wearing constrictive garments, which I've also already mentioned. Treatment tends to be very conservative, or sometimes they will do what's called a vein ligation and stripping, and you'll hear about that in class. But here's some pictures showing varicose veins on the left, and on the right it shows your normal vein. You see how the blood flow, the valve is closed and prevents the blood from going back down, or when the valve is open. They're very large twisted, painful superficial veins that result from poorly functioning valves, or your varicose veins. They usually occur in the veins of the legs, although it may occur elsewhere, and it's a common condition that mostly affects women. You can have chronic venous insufficiency, which is due to inadequate venous return to the heart. Symptoms are due to ischemia and slowed circulation. You get hyperpigmentation, which is vascular scarring, another term for that, where the lower extremities change color, they get more purplish. You'll also have venous stasis ulcers that are due to edema, cell death, and necrosis because of the toxins that stay in that area. And the toxins will remain in and around those cells longer, and because of the slowed circulation, they'll cause trauma to the cells, leading to cell death and necrosis. And as I've already mentioned, edema. And when you have extra fluid hanging around where it doesn't belong, in order to compensate, the body will third space some of that fluid, and that's what will cause that edema, because fluid's gone into the interstitial spaces rather than staying in the intravascular system. Here's a picture of stasis dermatitis, which can occur with venous insufficiency. Here's another picture of stasis dermatitis further up on the leg. And anytime you have stasis of blood, clots will form. So you have venous stasis in the first, that then proceeds to have platelets that clump on the wall to form the clot. And then you have inflammation in response, and a piece can break off and go to the lung. We discussed this with the hematologic system in much more detail. You might want to go back and review that. Disorders that affect stroke volume. One is disorders that affect afterload. Please remember that the ability of the heart to pump blood out and the amount of blood that is pumped out is called your cardiac output. Your cardiac output is affected or measured by taking your heart rate times your stroke volume. So anything that affects your heart rate affects cardiac output, and anything that affects the ability of the heart to pump out the blood or affects your stroke volume will affect your cardiac output. And your stroke volume is affected by your preload, which is the amount of blood returning to the heart, your afterload, or the pressure against which the heart must pump, and your contractility, which has to do with Starling's law. So first off, we're going to talk about disorders that affect stroke volume. The primary one is hypertension. Now, hypertension is when you have a consistent elevation of your systemic blood pressure above 140. Pre-hypertension is now considered anything 120 over 80 to 138 over 88. It's still considered normal, but it puts you at greater risk for hypertension. And hypertension is the silent killer, and it's silent because sometimes the only symptom you have is a headache. How many of you go to the doctor for a headache? Gotta take a couple Tylenol or a couple aspirin and hope it goes away. Headaches are important symptoms that something is wrong. It should be looked at. If you have them often, you need to keep track of how often and what you're doing and try and correlate what's going on with that. There are different types of hypertension. We've got primary or essential or idiopathic. They all mean the same thing. Basically, we don't know what causes it. But it affects about 90% of all people who have hypertension. And there are over 50 million Americans who have hypertension. Primary, if you look at it as a group, is due to an increase in cardiac output, an increase in total peripheral resistance. In other words, it could be the blood is too thick. There's vasoconstriction of the blood vessel that might be causing it. Its prevalence will increase with age. Women over the age of 50, blacks particularly, if you have a genetic predisposition, a diet that's high in sodium and low in potassium, magnesium, and calcium. But it's essential. We can't find anything actually wrong with the person per se. We can say they have these risk factors, and the more risk factors you have, the more likely you're going to have it, but it doesn't necessarily work that way. Now, complicated means that you have it involved with there are other disorders that go along with it, and we'll talk about the other types in a moment. But the types are, as I said, primary, complicated, malignant, secondary, or white coat. And the symptoms aren't any, except maybe a headache, until you have organ or vessel damage that occurs. Primary pathophysiology is chronic the problem with it is that chronic hypertension will damage the vessel walls because of prolonged vasoconstriction and high pressure. It will cause hyperplasia and hypertrophy of the vessel walls, resulting in permanent narrowing. Some of the causes. Increased volume. When you have an increase in cardiac output, that will increase your peripheral vascular resistance, causing an increase in blood pressure even when your cardiac output returns to normal. It could be inappropriate autoregulation, and in this the body seeks to maintain the status quo, tries to keep the body at a steady state. So if you're under prolonged stress, your blood pressure will elevate, and then even when that stressor is removed, your blood pressure will remain elevated because the body considers that the new norm. And then the next time you're under stress, it'll raise it again. And then that will consider it the new norm. And by the time you probably go to the doctor, your blood pressure is usually quite high. Overstimulation of sympathetic fibers by the brain or alpha fibers will cause vasoconstriction and will increase the blood pressure. You could have water and sodium retention that stimulates the reticular activating, the renin-angiotensin-aldosterone system, which will cause vasoconstriction, raising your blood pressure, cause the release of aldosterone, and the saving of sodium and water. Your hormonal inhibition of sodium and potassium transport in the kidney and the blood vessels can also raise the blood pressure. And endothelial injury and tissue ischemia decreases the production of your natural vasodilators like nitrous oxide, causing your vessels to remain constricted. So all those are possible causes of primary hypertension. And this is a flow sheet showing some of the different changes that occur in primary hypertension and how it will affect your cardiac output and how it causes sustained hypertension, which we've talked about. Malignant hypertension is a rapidly progressive hypertension with the diastolic blood pressure greater than 140. We're really concerned anytime that diastolic blood pressure is greater than 100 or 100 or greater, because that means even at rest, the heart has 100 millimeters of pressure pushing against it. Makes it much harder to contract, makes it much harder to relax and fill appropriately. It will cause cerebral encephalopathy, which is cerebral edema, and a decreased level of consciousness. It'll cause papilledema, which is edema in the eyes, cardiac failure, uremia, which is a renal problem, which we've talked about in the past, retinopathy, and a stroke, or CVA. Secondary hypertension means that it's due to another systemic disease process that increases either peripheral vascular resistance or cardiac output. And the primary disorder that causes secondary hypertension is renal disease. If you have kidney disease, that's going to affect your renin-angiotensin-aldosterone system, and that is going to cause an increase in hypertension. Remember, primary disease is of the system itself, so that'd be the cardiovascular system. Secondary is outside the cardiovascular system, so in this instance it'd be renal. Isolated systolic hypertension is due to an increase in cardiac output, a rigid aorta, and this tends to occur mainly in the elderly. Because as we age, we get lots of atherosclerosis, and the aorta gets stiffer and doesn't expand as well. White coat syndrome is when your blood pressure elevates when you see the physician or the nurse in a uniform ready to take your blood pressure, even though you know that's what they're going to do. And I have a great example of that with my own mother. She has been going to the same physician probably for the last 20-some years, maybe 30-some years. And at home, I check her blood pressure. Pressure's around 130/70. Maybe if she's been working, 140, but it never goes above that. At the physician's office, it's 168/88. If he just talks to her for a while, before he checks her blood pressure, lets her sit there, relax, get used to what's going on, and then checks her blood pressure, it'll be what it is at home. And she knows he only wants to help her. It's just the fact she sees the doctor, and just the fact that it's a doctor, any doctor, it causes the problem. Complicated hypertension, as I've mentioned, is sustained primary hypertension that damages various organs in the cardiac system. It causes an increase in workload, atherosclerosis, and a decrease in blood flow that can lead to heart failure, coronary artery disease, heart attack, angina, and sudden death. Vascular disease is when you have increased pressure, and that can cause aneurysm formation anywhere in the body, the brain, the heart, anywhere, blood vessels. Renal disease is due to the decrease in blood flow to the kidneys, which activates the renin-angiotensin-aldosterone system And again, renin is spelled wrong. It should be only one N. In the eyes, it'll cause a decrease in blood flow, retinal vascular sclerosis, and a blurred vision. In the brain, it causes decreased blood flow, decreased oxygen, the walls will weaken that could lead to a transient ischemic attack or a cerebral vascular accident, which is a stroke, aneurysm formation, hemorrhage, or thrombus formation. So it becomes very complicated in that it affects multiple systems and can cause major problems. Systemic hypertension in children tends to occur when the blood pressure is greater than the 95th percentile for age and gender on 3 different occasions. This is usually secondary in nature to some other problem. Child is oftentimes overweight and maybe smoking. And remember, children go to a pediatrician until they're 18. If it's primary hypertension, it's an older child and tends to have a genetic component with disturbance of your sympathetic vascular smooth muscle tone. You may have a problem with your humoral agents, your renal sodium excretion, or an increase in cardiac output. But systemic hypertension is just like the adult. There are no symptoms. There is a table on page 690 that talks about the symptoms that occur as it progresses. Page 689 lists the secondary causes, and in order to identify height-weight chart for this child, it's there also on page 689. So you'll want to look at those. Now, hypertension is not the only problem with blood pressure. Sometimes you have orthostatic hypotension, where your blood pressure drops when you change position to an upright from a lying position. If it's acute, it's due to an anatomic variation, medication side effect or action, which is probably the most common, prolonged immobility, another very frequent cause, hemorrhage, starvation, venous pooling, diuresis. When you give your patients diuretics to help dump lots of water and they dump a lot of it in a hurry, it will cause orthostatic hypotension, which will lead to an electrolyte imbalance, which can also cause this, pregnancy, or physical exhaustion. If it's chronic, it's due to an endocrine problem, such as adrenal insufficiency or diabetes. It could be due to a metabolic disorder or a central nervous system, parasympathetic nervous system problem. And if it's idiopathic or primary, it tends to occur between ages 40 and 70, more so in males than in females. Symptoms are those of decrease in cardiac output. So the first symptom you're going to notice is a change in the level of consciousness. Doesn't mean coma, could mean restlessness, confusion, disorientation. Coma is one of the last changes. We want to treat it before it gets that far. Blurred vision, syncope, decrease in their pulses, that sort of thing. Aneurysm formation is something else that might occur. Now, outpouching of a blood vessel wall or a cardiac chamber is what an aneurysm is, and it's due to atherosclerosis and hypertension. The law of Laplace says that the contractile force depends upon the radius of the chamber and the thickness of the wall. If you have a decreased radius and increased thickness, you're going to have an increase in force, so an increase in stretch of the wall. The radius is decreased with atherosclerosis, and over time, hypertension causes trauma to the vessel wall, making the walls thicker. There are different types of aneurysms. You've got fusiform, or true aneurysm, that involves all 3 layers of the vessel wall. Saccular, or a false aneurysm, which is due to trauma. A Berry aneurysm that occurs at the bifurcation of a vessel wall. Or dissecting, when the vessel walls split, the layers split, so that you get a break between the intima and the muscular wall, or vice versa. Symptoms are due to a decrease in blood flow to the tissues below the area of the aneurysm, or due to pressure on the surrounding tissues, but oftentimes there are no symptoms until it ruptures. They could include hair loss, cooler extremities, a decrease in pulse strength distal to the aneurysm, Symptoms are those of arterial insufficiency. Not enough arterial blood is getting there. Pressure on the surrounding tissues is a problem if the aneurysm is in the brain, where it becomes a space-occupying lesion and can increase intracranial pressure, or if it's in the thoracic cavity, where it could displace lung tissue, the esophagus, or the heart. And here are some diagrams of the different types of aneurysms. These are the most frequent sites. I haven't the faintest idea why the lecture just stopped in the middle. I hope this is continuing.